All right. So looking at treatment in PSA, to what extent do you think that the reasons for choosing specific advanced systemics in dermatology or rheumatology indications has changed over the last few years?
Yeah, so I think there have been a number of important advances. I mean, to begin with, on the in the psoriasis space, we have for a long time had the opportunity to look at head-to-head trials, head-to-head trials data to really get a sense of comparative effectiveness between these different MOAs, how impactful they can be, both in terms of disease severity but quality of life. I think it's more in the recent years that we've had the opportunity to unpack to some degree some head-to-head data around some of our agents in PSA, right? So I think it actually has been impactful to be able to see some of the IL-17 TNF data, for example, in PSA, to be able to really show that these are better in the skin with skin endpoints, that they're sort of as good, if not better, in some domains of disease for psoriatic arthritis. I think that's been an important advancement in our ability to have that conversation, both with rheumatologists but also with dermatologists. I think that's important. I think also just the very fact that we've had these advances, that we've been able to push the envelope on this, particularly on the psoriasis side, to clearer and clearer and clearer skin, has been important. On the flip side, there is still a bit of a gap in our ability to truly push the envelope around psoriatic arthritis outcomes. Those have been a little bit more stagnant by pure numbers, throughout the various MOAs and programs, that we've seen come out over the last few years.
So what we've been seeing in our dermatology data is that we see the importance of focusing on efficacy in skin and joints increasing, and this figure has been rising for a number of years. Do you think that that's translating into everyday practice? Are derms actually also thinking about joint disease as we see in our data?
I hope they are. I think there's always some implicit bias when you ask people if they're doing something. It's like when my dentist asks me if I'm brushing my teeth 3 times a day. I say, sure, it's less than that. So not to assume bias, but I think in the real world, in very busy practice, and also in the setting of, derm practices are changing. There are a lot of physician extenders and other folks, that are, taking part in that patient interaction. I think it may not happen as frequently as the data, here might suggest. And so I think there's always an opportunity to continue to facilitate that screening. One of the things we're interested in, are ways to have it brought direct to patient. I mean, I think that some of the, DTC efforts around PSA are important, but also, we have screening tools and other clinical tools that really can be given to patients in the waiting room. They can be given through, a patient portal before the patient comes or after the patient's seen, to facilitate that diagnosis. And I think those are some of the opportunities we have really to try to empower the patient to do this, and to really, further our ability to have people screened beyond what the dermatologist may be comfortable or able to do in the course of a busy visit.
So how often are dermatology offices using these practices of screening, adding the questionnaire into the waiting room, patient paperwork? How often is that being used, and is that easily applied across our US derm offices?
Yeah, so I think it's quite feasible. I don't think it is. It's a challenging intervention. I would argue it's probably not done terribly commonly. We've heard on the ground from some practices that have implemented it. The problem is there isn't a major incentive right now to implementing it. There is a process measure, one of these MIPS macro type process measures that can incentivize practices to use to do some PSA screening. So that might be somewhat of an incentive, but at the same time, I think it's something where I'd love to see you all probe some more practices around their willingness, and not only are they doing it, but what's their willingness to do it if they're not. How could they operationalize it? Because I don't think it's done as frequently as it probably could be still. So I think again, there's an opportunity there.
Well, we certainly just got our variable content for the next wave.
It's interesting hearing that from the dermatology perspective, because at this most recent wave that we went out for psoriatic arthritis, we were probing a little bit about from a rheumatologist perspective, are they checking for skin involvement? And the majority of physicians said that they are. They're checking things that are more visible, that the hands, the arms, the head, the scalp specifically. So it does seem to be happening across the board from that perspective. So it's interesting hearing that there's more room to grow from that dermatology perspective and doing that screening, but it sounds like from a rheum perspective that is happening. Do you agree with that?
I'm optimistic, and I hope that's the case. Many of us have been trying to not only talk about the need for psoriatic arthritis screening and the impact of not doing it, and getting patients to a timely diagnosis. I think the other piece to your point is helping dermatologists and others to understand what some of the at-risk features are for developing psoriatic arthritis, so that in their minds, they're also risk stratifying at that visit, looking for, as you said, scalp disease, sometimes, nail disease, other features that may actually be associated with increased risk of development of psoriatic arthritis. And so I think there are more nuance, here around how we can get patients to be screened and to be referred or managed appropriately. The other piece we didn't talk a lot about is that the dermatologist in 2021, with all the options we have, especially many of which are very much PSA facing, that the other option here is for the dermatologist to just directly own the treatment of the psoriatic arthritis. And that's actually also a very viable option. And globally, when we talk to folks in different geographic regions around the world, there are dermatologists who feel they do own the PSA treatment and they do it themselves. So that, I'm not sure that we'll bring our American dermatologists around to that immediately, but I think it is, another path for them to follow in getting patients to the right therapy.
So going off of that derms are owning the PSA piece, when Maxine and I ran our PSA rheum and derm study earlier this year, we did have a large number of derms saying that they are the primary treater of this patient's PSA. The main difference that we saw between the two patient types amongst derms and rheums is that our derms are treating lesser severity. So they're seeing the more mild patients, a little bit of moderate, and the rheumatologists, they're seeing the more moderate and severe folks. Is that something that you think is something that we're seeing in the US, that derms feel confident in treating mild, then when it gets too severe, they're giving it over to the rheumatologist?
Yeah, absolutely. I think on two fronts. Number one, the patient who presents with more severe arthritis, is not likely to necessarily present to their dermatologist, number one. Number two, they may not even realize the connection between the skin and joint disease. And so I think those tend to present to the primary doctor, to the orthopedic surgeon, to the rheumatologist first. And so they're seeing that skewed population. So when you ask a rheumatologist who they see, they'll say it's the people with, bad joint disease, but with often also they'll say it's the folks who have less or mild psoriatic skin disease. So they'll say, oh yes, I see the patient with a couple of skin plaques, but they really have joint disease. And on the flip side, the dermatologists are seeing the people where the skin really bothers them, and potentially it could be more mild joint disease. It doesn't have to be. I think it would be skewed that way, based on referral patterns I see. I also think it's more likely that they may see some of the soft tissue arthritis. So the patients who have more of the enthesitis, tendinitis type disease, where it's a little bit under the radar, or less, obviously attributable, whereas, a big red hot swollen knee with fluid in it, the patient's probably going to bring that up or bring it up to a different provider potentially. So I think there is some skewedness in who's seeing which phenotype or severity of patient.
So outside of rheumatologists having access to JAKs for PSA, let's think about prescribing now and the behavior of which rheumatologists versus dermatologists are prescribing it. How do you think that those physicians differ?
Yeah, so to begin with, rheumatologists have had JAKs in their arsenal for a number of years now, right? I mean, we've had it for rheumatoid arthritis, and then ultimately for psoriatic arthritis, and so it's there's already a familiarity with the JAK class in rheumatology. I mean, obviously, we'll come to the oral surveillance results and some of those, more recent data that might also change the way rheumatologists feel about where it falls in their algorithm, et cetera, et cetera. I think on the dermatology side, I mean, as of our discussion today, there still is not a JAK, a systemic oral JAK formally approved in any indication in dermatology. Now that's coming, I'm sure, around atopic dermatitis, around some other indications. But at the same time, I think, dermatologists tend to be fairly risk averse. They don't really have necessarily the time or support to spend on heavy monitoring, on heavy counseling in the office. So I do think that, some of that may be limiting in the dermatology space. I mean, there's a tremendous unmet need in, across dermatology for, that the JAKs can fill and hopefully will fill. But I think it's going to restrict those who are comfortable with prescribing, those who are willing to prescribe. And so I think it, just to say, I don't think it necessarily will take off like wildfire out of the starting gate for all of those reasons. I'm also hoping, again, to our earlier points about collaboration between specialties, that, that might also help facilitate the conversation, to hear, dermatologists and rheumatologists talking about their experience with the medication over the years, to help facilitate the comfort, the monitoring recommendations, the in-office discussions, what's pertinent, what to emphasize. I think all of that will be coming, in the near future.
And as new products come to the market, I mean, we talked a little bit about that already, but it's providing more opportunities and options for rheumatologists and dermatologists, right? So do you think that the use of TNF specific to that first line is going to dwindle as more use of the alternate mechanism of actions increases?
It's interesting. And on the rheumatology side, I mean, it's probably a bit harder to kick the TNF king out of its off its throne. I think we have such a long experience now with using anti-TNFs in psoriatic arthritis. There's a wealth of data, both safety and efficacy data. And so I think, for many rheumatologists who are also using them and familiar with them from other areas, right? Whether it's other spondyloarthritis, whether it's rheumatoid arthritis, I think that's, it's very much ingrained. And, some of our guidelines also emphasize use of, agents such as anti-TNF before even the use of methotrexate in psoriatic arthritis. So I think, there's a lot of reasons why TNF has been a go-to, including access, of course, among other things. That said, I think we now have, absolutely sufficient data to suggest that IL-17 agents in particular really should be considered first-line agents alongside TNFs, especially for folks who have more skin disease, because we do have head-to-head data that it's better in the skin. There's arguably, better or a little bit less concerning safety data with regard to infection, among other things. So to me, that's a class that really is at the forefront of our psoriatic disease therapy. The place where the rheumatologist may lag behind in uptake, I think, is more in the IL-23 space, where dermatologists are. That's a very much a go-to for severe psoriasis, moderate severe psoriasis, for a variety of reasons. But where, rheumatologists, I think, are still maybe making some connections between their experiences with IL-12/23, ustekinumab in PSA, and where the data falls now for guselkumab or zinzikimab, which looks good. But, at the same time, there are nuances, I think, that may give the rheumatologist a bit of pause in using that first line, as opposed to either second line or more so for patients maybe with more mild psoriatic arthritis who have, predominant skin disease, for example. And we'll see how these trends change over time, but I think that would be the current kind of feeling and thinking. And then, of course, coming back to the JAK class, I think that with some of the recent warnings and likely, some changes in practice patterns around rheumatoid arthritis, where it will likely be used more so after first line biologic therapy, that may, well impact and should impact psoriatic arthritis use as well. In particular, I think that is it's a bit unfortunate in some respects, because looking at the data, for example, from upadacitinib in psoriatic arthritis, where the data is quite robust, their outcomes in psoriatic arthritis look very good, including even in skin from their PSA trials. I think there's an opportunity there to bridge a gap for many of our patients who either want an oral therapy or who have failed other therapies. So I'm hoping that they all find their place in our armamentarium.
From a dermatology perspective, do you think the IL-23 class will be able to compete with the IL-17s on joint efficacy?
It's a great question. I mean, obviously, we don't have a head-to-head. I'm not sure if we ever will have a head-to-head against those particular agents. I think the current understanding is, at present, that the IL-17s are probably a bit more psoriatic arthritis facing for a few reasons. I mean, we know that they have data in axial psoriatic arthritis, which is one of the domains of disease that's not terribly uncommon in psoriatic arthritis. Maybe 20-30% of our PSA patients have been, depending on the prevalence estimates, reported to have that axial component. They have inhibition of radiographic progression data, which is variably weighted by my rheumatology colleagues, but I think it's something that may give it a little more strength as a sort of PSA facing drug. Again, we have those head-to-heads with anti-TNF drugs in PSA. So I think for a variety of reasons, the IL-23s may be looked at a little bit lower on our go-to list for psoriatic arthritis as a rheumatologist. Now, on the dermatology side, where IL-23s are, again, at the forefront, they are, first line when we have access to them for psoriasis. I think it's seen actually just as a reassurance to the dermatologist that they work for PSA. Hey, they're approved for PSA. I'm sort of covering my bases here with patients who may have some, more mild, moderate type psoriatic arthritis. And so I think, if anything, the dermatologists may be thinking more about their use in PSA at present. We'll see how that plays out.
And back to lines of therapy, do you think when a derm is treating a patient that has psoriasis and PSA, what line of therapy do you think a derm would pick for an IL-23 agent versus a rheumatologist?
It's interesting. I think that the dermatology community really has embraced IL-23 and IL-17 for skin disease, more so than anti-TNF therapy for that more severe skin disease at present. If they were, if everything was equal and everything was laying out on the table, payer access aside. So, I think there's still an opportunity for conversation there with the dermatologist about, if they have someone who they have in front of them with known psoriatic arthritis. I would argue that there are probably different phenotypes that might push my hand one way or the other, meaning if they have, more severe polyarticular erosive disease, I might, push toward an IL-17 agent where I have inhibition of radiographic progression data, I have more robust, maybe psoriatic arthritis data. Whereas if I have a patient who has, predominantly seen me for predominantly skin disease, they're achy, they've had some, tendinitis on occasion, I think that would be a fine patient to think about the IL-23 inhibitor in, as long as I'm comfortable with that, monitoring over time, for progression, et cetera. So I think the dermatologist is comfortable with both classes. I think they're just, they're using so much of the IL-23s on the skin that's likely to impact how they think about PSA and PSA impact. the other big question for us is what will happen when people's skin is well cleared by the dermatologist, they're on an IL-23, and then they develop new onset psoriatic arthritis symptoms, or they're having breakthrough arthritis, in which case, what's going to happen then with the rheumatologist? Will the rheumatologist keep them on drug, add agents to try to control the joints? Will they be switching? What will they be switching to? Is it TNF? Is it 17? I think all of those questions, have yet to be answered.